Thank you. So this is to lead on from this morning with talking about access for patients. I'm actually not from John Hunter Hospital, I'm actually from Taree Hospital, Manning Hospital, and my co-workers that are sitting in the row here, they're not going to get away lightly. I'm going to get them to stand up so that they can also introduce themselves. Karen Dada is our Rural Cancer Care Coordinator who's actually away, so I can't introduce her. Annette Davis is our Breast and Gynae Coordinator, so I'm going to get Annette to stand up and turn around and introduce herself. I do the haematology and cancer care coordination, and I'm also a CNC. Rachel Pitt is our brilliant nurse practitioner in Taree, and Jenny Rutherford, who used to work in gynae oncology, is now works in clinical telehealth. So she's the person, if anyone wants to know about telehealth, to ask. Oops, wrong way. Okay. So just so you know, Manning Hospital, Taree Hospital is on the North Coast for anyone that doesn't know. We service Taree, Foster and the Great Lakes area. We have a small oncology unit that have 6 treating chairs, but we also have access to 4 chairs in the private hospital as well. So we have a public-private agreement, which is a bit of an unusual circumstance. So we have 10 chairs. We only have 1 treating oncologist, which means that we have a lot of patients that can't get their treatment in a timely manner, so have to travel out of area. So hence that's why we're using telehealth now. So we're hoping to decrease some of our patients' emotional, physical and financial burdens, which the patients are loving it, I have to say. Part of the 2018 strategic plan is to improve equity and access to service delivery for our patients, and this is one way that we can really do this. So we've got a couple of patient stories just to sort of show you how we actually utilise telehealth. The first one is a 70-year-old patient from Taree that was having treatment for a brain tumour with the Mater Newcastle Oncology Group. He had had his treatment in Newcastle and had came home but became very unwell, ended up in the private hospital at Mayo. And scans had showed that his disease had progressed. It was decided that he would really benefit from a further discussion with his medical oncologist as far as what the next stage should be, which was going to be palliation with supportive care. But his family was really keen to have that discussion with the oncologist. So our very innovative cancer care coordinator, Karen Dada, got the laptop, took it out to the bedside and organised a review with the Mater medical oncologist, which the family really appreciated, and obviously the patient did as well because he had that final consult with his medical oncologist, whereas previously it would have been the physician giving him that final news and he wouldn't have had that final exit from his medical oncologist to have that final review. The next one is a very complicated young man who lives at Foster. He's actually having second-line treatment for a Hodgkin's lymphoma. He has very complicated social and lifestyle choices, which really impact greatly on his compliance and continuation of his treatment. So the only way that we felt that we could really treat this man effectively and continually was to really include his GP in the actual consults. So what we've done is actually go out to Foster to the GP surgery, and the GP does the teleconsult with his haematologist in Newcastle. This has been very effective, and so far we've been able to keep this young boy on track, and he's up to his seventh cycle of treatment. GP also found it really a really excellent way of doing a consult. He'd actually dealt with this particular haematologist for many years, not just with haematology patients, but also with practicing new recruit GPs, traineeships. So he'd never actually met the GP, the haematologist face to face. So he sort of went, oh wow, that's what Phil Rowlings looks like. There you go. So it was really beneficial for him as well. The next one is a 60-year-old man, and this is where the nurse practitioner comes in. I utilise a nurse practitioner in all the consults, teleconsults for the physical examination and anything that needs to be followed up on. So this was a 60-year-old man who had a diffuse large B-cell lymphoma. On diagnosis, he was very unwell, transferred to Mater, and he had his first cycle of chemotherapy urgently at Mater. Came home and he was still quite unwell, and when he came in for his second cycle, we decided to do a telehealth because he didn't want to go back to Newcastle. He found the travel quite exhausting. So the nurse practitioner sat in and was able to do the physical examination and actually discuss it with the haematologist as far as that he did show that he had quite a good response to treatment, so that then he could make that decision whether to go on. He was quite reluctant to continue on with treatment. He was really wanting to go more natural therapy rather than, because he'd had such a great response. We did get one more cycle into him, but then he decided to do natural treatment, unfortunately. So far we haven't seen him back. The next one is one of the breast care patients. She actually lives at Gloucester, which is about an hour from Taree, and for travel to Newcastle it's about an hour and a half. 43-year-old single lady with 3 children, who one has a medical condition which requires a lot of hospital and medical intervention, so she does a lot of travel. Was really feeling that she'd had enough of the travel having to go to see specialists. Our breast care nurse also works in Gloucester 1 day a week, so we organised a telehealth consult with the breast care nurse there with her at one end, nurse practitioner on the other, and they discussed the C2 results, which happened to be, she didn't actually have any disease progression, which is why she had the CT, so it was a very good consult, and she was very happy to be able to discuss that with the nurse practitioner. This is actually one of our telehealth consults. This gentleman, when I asked permission to take this photo, asked would I please pass on to everybody in the audience. It's not just the travel to and from the consults, but it's also parking. It's always very difficult, same as in Sydney, I'm sure, getting to and from the consults into the actual clinic. Often accommodation needs to be sought because if it's a late consult. And also, it's usually a 3 to 7 minute consult. So it's a long way to go for a 7-minute consult when we can do it at home in Taree, which takes him 15 minutes to get to his actual consult. So he's very happy and very reluctant to go back to Mater, but he will have to at some stage, as is most of the patients. When Jenny extracted data from our electronic medical system, ARIA, it was very difficult because unfortunately what had happened, it's a new system as far as clinical telehealth, and people were still putting it into their diaries, not into the system as far as the consult. So this is very understated as far as how many we've got. These are mostly haematology and gynae telehealth consults, but there are a lot of medical oncology that haven't been correctly put in. But it just gives you an idea of the estimated cost that it saves the patients and also the kilometres it saves. But once again, as I said, that is quite understated. Hopefully we'll get better at it. So the benefits: efficient use of available resource, obviously. Patient satisfaction, I mean, our patients are really happy with it. I did another one this week with the patient on his 3rd cycle, hadn't had one before, had been going backwards and forwards. And he said, I'm not going back to number 6, that's it. You can do them all in Taree. Tailored support, we're able to tailor what support's needed for the patient, so we can have the nurse practitioner there. We can do specialist to specialist if need be. So it's very efficient. Reduced travel, obviously. Better than a phone consult, so they've got that face-to-face, and even for consultants, such as I said, the GP, he was able to see what the actual physician or specialist that he'd been dealing with for years looked like. Flexibility of the telehealth, you can take it to the bedside, you can go to the GP, go to other institutions, aged care, wherever you need to go. Difficult of scheduling sometimes if there's 2 specialists, obviously at the time it can be difficult as far as getting the 2 to agree to a time, but so far we haven't had major difficulties with that. Obviously we're dealing with technology, so sometimes there are intermittent difficulties. However, if you've got a great support system, then that's really essential to your success, which we do have in Hunter, New England. Patient experience, so these are just some of the satisfaction surveys that we did. Questionnaires, obviously they're all very happy with the actual experience that the telehealth is giving them instead of having to travel. That's some of the comments. Good, great, excellent, very informative. Jenny, you might like to explain the actual complexity of how this works.
In Hunter, New England, there are 2 ways that we can There are two ways that we actually can access patients. If they're within a health service, we can link via Polycom system, but we also have another program called Scopia, which is very much like Skype, but it's safe, secure, encrypted for patient consultations. So that's the device that we use, or the program we use when patients are in their home. So they can be on their iPad, their iPhone, laptop, whatever device they have, and the same with the GP practices. So I've had patients take their laptop to the GP practice if the GP practice isn't set up. Having said that, many rural practices are set up. And also within the health services, there are rooms, community health rooms, all the MPSs are set up with telehealth facilities where patients can go. But this scenario with the oncology setting, it works so well when they've got the support of their local oncology team linking directly through. So it's just a direct link through the hospital connection. Connections are generally very good. Obviously, if the patient's at home or in their local community, depends on internet connectivity. But I've got to say, I've been in this role now 18 months, and even in that time, we all know that connectivity is getting a lot better. And of course, that's something in my role I check to ensure that connection is good for that patient or that consultation before that link, if they're somewhere outside the health service.
Thanks, Jen. So excellence, telehealth's an obvious example of excellence, every patient, every time. So for anyone in the city, if you do have rural patients, really consider telehealth. If it's Hunter New England, then as Jen said, they're there to help connect you to the area. And if they're within our area, then we're more than happy to facilitate that. So thank you.